as you can immediately see, I probably have too many slides here. But thanks to the organizers for allowing me to speak to you on this subject. It's rather strange maybe when we're talking about new innovations for me to be talking to you about the oldest anti-tuberculosis drug that there is. I'm going to tell you a little bit of history. These are my co-workers, whom I thank, and I thank in particular the National Research Foundation of South Africa for supporting some of this. Okay, so I'm going to give you a bit of a historical background to tell you where our research fits in, and also to elucidate or attempt to elucidate where our current dosage recommendations for PAS come from. Then to tell you towards the end about our original research with PAS and the influence of the dosage on tolerance and the influence of genes. Okay, so an alternative title here, and I'm just starting my stopwatch so that we can see that I don't go over the time, and could be a reconsideration of the current dosing recommendations for PAS. We start right at the beginning with this man, Jorge Lemon, who was a Dutch doctor, physician working in Sweden, who was the discoverer of PAS, and he started his first clinical trials of PAS in March 1944, about a month before streptomycin was used. It was this paper that precipitated it. Frank Bernheim, an American researcher who was culturing mycobacteria, and he gave some salicylate added some salicylate to the culture media and stimulated the oxygen uptake. And immediately, Jorge Lemon, who was experienced in blocking enzymes, saw that there was a potential for a compound which might block the activity of that pathway. So he took the aspirin, put an amino group down here at the para position, and then we had para-aminosalicylic acid. Now, obviously, it was much more difficult than this, but that's very simply what happened. In the early 50s, the British MRC conducted a series of trials which threw quite a lot of light on how we should dose our early anti-tuberculosis drugs. So here's the 1950 paper where they looked at PAS alone, streptomycin alone, and the combination of PAS and streptomycin. Their main concern was the protection of streptomycin against resistance. I ask you to note the dosage of PAS, 20 grams in 4 equal doses, so each dose here was 5 grams. And the outcome after 6 months, the PAS streptomycin group, not unexpectedly, fared better. Negative sputum cultures in about a quarter of the PAS streptomycin patients, and somewhere over 10% for the streptomycin alone and PAS group. But most importantly, streptomycin resistance in 2/3 of the streptomycin alone patients and only 10% of the PAS streptomycin patients. On 5-year follow-up, a third or more of the PAS and streptomycin alone group had died, only 19% of the PAS streptomycin group, and the principle of combination anti-tuberculosis therapy was established. It was this figure which stimulated us to actually go and have a look at what we're doing currently, as this figure of survival after 5 years is quite a lot better than our current management of multi-drug and extensively drug-resistant tuberculosis. Okay, in the next study, which involved PAS, they looked at different dosages, 5, 10, and 20 grams with the same dosage of streptomycin in each case. But these dosages were 4 times 1.25 grams, 4 times 2.5, and 4 times 5. So in each of these patient groups, the patients were arguably exposed to higher Cmax concentrations of the PAS. At 6 months assessment, there were almost no deaths. Streptomycin resistance emerged in 36% of the PAS 5-gram group, 30% of the PAS 10-gram group, but only 7% of the 20-gram patients. Now, in the meantime, isoniazid had arrived on the scene, and this, of course, is a much more powerful drug than either streptomycin or PAS. And there was a great deal of interest. I think I skipped I think I've left something out there, but never mind. There was a great deal of interest in. I'm not having a success here, right? Okay, there we go. Okay, with isoniazid around, there was and PAS, there was quite a lot of interest in a totally oral regimen, which would have obvious advantages. So they looked at isoniazid 200 milligrams in 2 equal doses. So quite a lot of our early treatment of tuberculosis was with intermittent therapy, because it was thought that was the way to do it then. PAS was then given in 10 grams or 20 grams this being in 2 equal doses, so it's 5 grams times 2, and now 5 grams times 4. So the C max concentrations in these patients were arguably, again, fairly close to one another as opposed to the previous study. And at the end of 3 months, about 3/4 of the patients in both groups were bacteriologically negative. There was almost no emergence of resistance. 2 patients in the PAS 10-gram group acquired isoniazid resistance. So from this point onwards, sodium PAS was given in 10 to 12 grams daily in 2 to 3 doses. And in more recent recommendations, this has been reduced in some cases to 8 grams times 2 4-gram doses. Right, now a quick look at the sodium PAS pharmacokinetics. This is a study done by Citron and Cooper in Britain. And they looked at a number of different formulations. At one time, there were about 60 different formulations of PAS doing the rounds. But they looked at sodium PAS, 5 grams, and they had the C max was at about 2 hours with this preparation, and the C max concentrations were a mean of 100 micrograms per mol, with the lowest C maxes being in the region of 50 micrograms per mol. And in their paper, they suggest that these are the concentrations that we should aim at when we are using PAS. So this is not a direct evaluation of efficacy, but a interpretation of their results. Intolerance is an acknowledged problem, and I don't want to say too much about it because I think we all recognize it, but it's interesting that in early studies it was very high. Half of the patients that got PAS in the United States refused to take it. In some of the European studies, however, it was much lower. There's a resume of this in a paper which will be in Lancet Infectious Diseases in a week's time, I think, if you want to look up all of the references. Okay. Now, although PAS was being used in divided doses, there were a number of researchers who reported better or equivalent intolerance with once daily PAS. Not time to go into it more, but the references are provided here. And recently, when they looked at XDR patients in South Africa who had been taking PAS and had PAS withdrawn, the figure was 6.9%. Looking over many studies in the literature, the proportion was about 10% of patients who had to stop PAS. So intolerance is a problem. Pharmacokinetics. Acetylation of the amino group of the PAS molecule to form acetyl PAS and conjugation of the carboxyl group to form glycine PAS are the 2 commonest means of excretion for PAS. These activities are strongly influenced by dosage. At low dosage, PAS is rapidly absorbed and is equally rapidly acetylated. So the PAS concentrations don't get very high, and your PAS concentrations and acetyl PAS concentrations will be almost the same. And I'll show you a figure now. I've done that again. Okay. Okay. One of Jorge Lemon's last papers in 1969 had this figure which shows you the effect of different dosages and the effect on the concentrations in acetyl and glycine PAS. Okay. This is 100 micrograms per mol here, which I'm not trying to say that this is what we should aim at, but it's what people have suggested is not a bad concentration to aim at. And it forms a bit of a continuing focus in some of the other slides, which I will show you. Okay, so there's 100, 4 grams, 8 grams, 12 grams sodium PAS in one dose, fairly rapid absorption, Cmax at 2 hours, and concentrations, mean Cmax concentrations 100, 150, 200 micrograms per mol. This here is glycine PAS, and you can see how it gets more and more, and how the acetyl PAS starts to rise towards the end there as the concentrations are falling. This is probably due to the lack of acetyl-CoA for the acetylation process. Now, we usually think of PAS as a bacteriostatic drug. If you look at the literature, this can be questioned. This is the very first study which was done in Sweden where the drug was initially used. This was a blinded placebo-controlled trial. So they didn't just put the patients in the bed and give PAS to the one group. They had a placebo which they were matched with. So here you see the percentage of smears containing acid-fast bacilli. There's 4 weeks there. This is the PAS group. That's the placebo group. And you can see a fairly marked fall in acid-fast bacilli. And there are several other studies in the literature where this is also evident. Here we have PAS given in monotherapy again in a study carried out in Germany, published 1969. PAS dosage of 4 grams, 2 statistical methods used here to analyze. And again, 1, 2, 3, 4, 5 weeks, 6 weeks, and you see a fall in acid-fast bacilli. The same group again in Germany, PAS intravenously, and I think PAS is still being used intravenously in Europe in some sites, ethionamide cyclocerin, and then most interestingly, INH. So the PAS IV, which would arguably give you very high concentrations, is giving you a fall in acid-fast bacilli, which is parallel to that of INH. Obviously, they got different starting points here. So, and then lastly, quite a well-known study of Amina Jandani and Dennis Mitchison, one of the most often quoted early bactericidal activity studies, and has been overlooked that there was a PAS group in the study that got 15 grams PAS in a single daily dose. And the EBA 0 to 2 days was 0.26 log 10 CFU moles per sputum per day. In other words, a quarter of a log of acid-fast bacilli, or viable colony-forming units were removed from the sputum by the drug. Now, all of this says to me that we're not necessarily here dealing with a bacteriostatic drug, and quite likely, if you can give enough of the drug, it's actually bactericidal. Okay, with the development of rifampicin, ethambutol, pyrazinamide, the use of PAS dropped dramatically and it became almost unobtainable. And I think from the patient's point of view, this was quite a good idea. You know, no one enjoyed the nausea. In 1994, under the influence of the spread of HIV and the accompanying XDR and MDR epidemic, a new gastro-resistant granule formulation was introduced in the United States and was used in the management of MDR and XDR patients. Now, the idea of this was that you would give a slow release of PAS, a prolonged period of PAS at concentrations above 2 micrograms per mil. So there wasn't great concern here about how high it should go, but rather that on the basis that we're dealing with a bacteriostatic drug, that it would be maintain a concentration above 2 micrograms per mil. Chuck Peliquin has done a couple of pharmacokinetic studies. He's the doyen of American anti-tuberculosis drug pharmacists, or pharmacology experts. Pharmacist is not the right word. And here you see a single dose of the new granular preparation, 4 grams. This is 8 hours here. I apologize for the figure. I've colored in the acetyl PAS here, and here is the PAS itself. And here you see 12 micrograms per mil. And what I wanted to show here was that the acetyl PAS rises just about as high as the PAS does at this low dosage. He did several more multi-dose studies where the PAS concentration reached about 20 micrograms per mil in their patients. Right. Okay, so now we come to what we did, and I've got another 8 minutes. Something like that. Less, because you're late. Okay. Right, we're going to keep on racing along. Okay, this was a 2-period open-label crossover study, 32 patients, and they were randomized to receive one of 2 regimens, and they were randomized also to receive it either as the first option or the second option. So and then they were crossed over after they'd got the one regimen. 8 grams once in the morning, 4 grams 12 hourly. And we took blood at 9 occasions. We did HPLC tandem MS analysis of the PAS concentrations, unfortunately not the acetyl PAS. And we assessed intolerance by visual analog scales. I think most of you will be familiar with that, and I don't think there's time to really go into too much, but we asked the patients to rate how sick they were at the end of each day, how nauseous they were. This is the broad pharmacokinetics, Cmax, AUC, 12-hour concentrations. You see 4 grams twice daily, 8 grams once daily, and the 8-gram once daily patients not unexpectedly have higher concentrations. And conversely, if you look at the concentration at 12 hours, the concentration at 24 hours, in the 4-gram twice daily group, it's higher than in the 8 grams once daily group. It's interesting to look at the actual line graphs, and I think this gives you a much clearer picture of what's going on. This is 4 grams PAS 12 hourly. Here's 50 micrograms per mil, 100 micrograms per mil. And depending upon how you look at this, you can interpret it. Nearly all these patients will have concentrations consistently above 2 micrograms per mil. There are a couple of patients here who get to over 100, and some patients are getting above 50 micrograms per mol. Here is the 8 grams PAS once daily. Some patients getting over 100, all of them getting over 50, but quite a lot of them getting to naught at 24 hours. So I think I've told you this. We needn't spend too much time on this. Some interesting PK findings. Women had significantly higher Cmax concentrations and AUC 0 to 12 hours than men. Here you see the men and the women, Cmax, AUC 0 to 12, 8 grams, 4 grams, and the women have higher concentrations than the men. Our statisticians corrected these for body weight, as that might have been a confounding variable. Intolerance, 4 grams to the left, 8 grams to the right. First of all, occurrence, quite high levels of occurrence, as one would expect, but this is a fairly liberal documentation of intolerance. You just had to say you felt nauseous once, and it was noted as having occurred. One of the important things to note is that the 8 grams once daily patients have no worse frequency of intolerance than the 4 gram patients, and in fact some of the findings are a bit less. If you look at severity, 4 grams to the left again, 8 grams right. These are the median VAS scores and the range, and from the median scores you can see that no one actually rated their experience too badly. The range tells you, actually no one's not the correct word, sorry. There are individual patients who have high scores, but the median scores are very low. If you want a line drawing to make it clearer, I often find line drawings and things like that easier to understand. You can see that the means again are very low. I'm just going to go through this fairly quickly. I think I've showed you the basic data. This is diarrhea and nausea, and there were more patients who complained more vocally of diarrhea and nausea than there were of the other factors of intolerance. Majority of patients had no vomiting, and the observed median frequency of vomiting was 0. The percentage of patients complaining of intolerance was lower in women than men, despite them having higher concentrations, but only in the case of abdominal pain and cramps and nausea was it higher. Our statistician, who's a woman, said she always knew women were tougher than men. Okay, I've got to get through here. I'm being threatened. Okay, so I've virtually told you this, that there was no relationship between the intolerance and the PK. Genetics, the expected proportion of slow acetylators here, and the genotype. This is the PAS concentrations, 100 micrograms per mol there, with the number of alleles carried. And there was another gene which we identified, NAT1-10-3, which also had a slow phenotype. This hasn't been seen clinically before. It's been described in vitro situations. The NAT2, there was an intriguing association between some of the NAT2 alleles, and we had a very high proportion of fast acetylators, as one would expect in a southern African population. NAT2S1, higher concentrations, and NAT2S2, lower concentrations. HIV infection, lower concentrations, but not significantly so. And then very quickly, I want to draw attention to the mutant protection concentration. In this study here, this particular gene was investigated, the mutants. They had very high MICs, 128 micrograms per mol. So you'd have to give much more PAS than we did to actually exceed that MIC. But they did note that the growth of PAS isolates encoding wild-type proteins was dose-dependent in its response to PAS. And this is a very recent European study from Eric Botker's laboratory in Zurich. PAS susceptibility from a number of European laboratories. He asked them to do MICs on all of their MDR, XDR isolates. And the German is looking at his watch. And what I want you to note is that more than half of the PAS-resistant isolates had concentrations less than 64 micrograms per mol. So if you give a higher dose, you're going to exceed those. And so conclusions. PAS is usually classified as bacteriostatic, but I think there's quite good evidence that it's bactericidal. Intolerance to PAS is probably no worse following once-a-day dosing than multiple dosing. And I think then for certain groups of patients who've got to be treated for MDR, XDR, I would go for the highest dose that those patients can tolerate. I don't think on the data we have we can prescribe what the dosage should be, but I think if the patient can tolerate more, give them more. Okay, right, we can leave it at that. An acid-fast bacilli from Cape Town. Thank you.
Thank you very much for the very interesting talk. Any questions?
Do any of you use PAS?
Maybe I will start with the question.
Yeah.
So what's PAS first?
Para-aminosalicylic acid.
Yeah, what does that mean? So it's just a chemical drug. It's not an antibiotic, right?
No, it doesn't have activity against any other organisms.
Okay.
And it depends how you define the word antibiotic.
Okay.
But if you want to be pure and say it comes from another organism or something, microorganism,
Sure.
it's a chemical, it's a chemotherapy.
Okay. So the idea is you're trying all sorts of schedules, and what's the idea? To keep the PAS high in the plasma as long
Look,
as
our interest came because there's actually no data. You see, this is the situation in which anti-tuberculosis chemotherapy finds itself. That we're now reaching back 70 years still to use a drug. It's been resuscitated, which was never really thoroughly investigated. And on reading the literature and with our experience here, we feel that if you're going to manage multi-drug resistant tuberculosis, and it's the MDR and XDR patients that need PAS, their lives depend on it. And we have the recommendation from WHO and from other authorities that you actually give a really low dose. As they half-jokingly say, a touch of PAS. Whereas my interpretation of the literature is the more you can give, the better your results are probably going to be. And if your patient can tolerate it, and I think our experience here shows, and the reported experience in the older literature, shows that you can go quite high with some patients. In fact, with the majority of patients. And I think from the evidence that I see that I would prefer to give a much higher dose. And if you compare PAS to the aminoglycosides, if you use amikacin or kanamycin to treat your tuberculosis patients or MDR patients, about a quarter of the patients, a third, become deaf. I would rather have nausea and diarrhea for 6 months than be permanently deaf.
But maybe 50 years ago they could sustain these adverse reactions better. And now I think maybe our regulations are a little bit stricter. So
you're talking about patients who have no other therapeutic recourse. They are therapeutically destitute, to put it bluntly. So you're talking about their last port of call.
I see. Go ahead, please. Yeah, there's a question there.
Thank you very much for the very interesting, because this particular product is really very interesting, because when you consider the prevalence of XDR, MDR in Africa, especially in Nigeria, you find this topic very interesting. How do you link pharmaceutical companies to actually use these products? Because managers of MDR, they still have a lot of resistance to second line drug management for MDR. So what efforts do you make with pharmaceutical companies in bringing
The only pharmaceutical company we've had any interaction with are the manufacturers of PASA. And we've had that interaction because they came to us when we published our results because they were interested in them. But their current formulation was drawn up on the supposition that PAS is a bacteriostatic drug and that you had to prevent intolerance as much as possible and keep the concentration as low as possible. And I don't think that's true. But now, because PAS was last investigated 50 years ago in any thorough manner, I can't offer you a guarantee that what I'm saying is therapeutically true, but I suspect very much that it would be. And we need to do the studies. But there's a lot of competition now for doing studies and for facilities with the newer drugs, which is quite appropriate. I have no argument with that. But if you have to use PAS, I feel very strongly give as much as you can.
Take one more question.
Do you think use of PAS with rifampicin or isoniazid will bring down the dose of PAS? And
Okay.
in return, it may stop emergence of drug resistance against
Because the question is about whether we should use isoniazid, or whether you could use PAS with isoniazid and rifampicin. I think if you're using, if your patient is susceptible to isoniazid and rifampicin and other first-line drugs, PAS has no role. Its role is in patients who've got isoniazid and rifampicin resistance, and even there you possibly have enough reserve drugs. But once you get to your XDR patients where they've lost the fluoroquinolones, they've lost the aminoglycosides, then you're really down to drugs like cycloserine. You're scraping the barrel with amoxil and clavulanic acid. And I think PAS is one of the last drugs that those patients have. And under those circumstances, I think we should be, using it at as high a dosage as we can. We need to collect more data, obviously.
Thank you very much.
Thank you, Peter.